So wanted to acknowledge and thank you for taking the time to be here today. My name is Joanie Bouchard. I am the Interim Chief Regulatory Officer for the college. We're very pleased to be here today for our third licensee webinar on standard and regulation changes. This is something we had identified as a need when we did our HPOA webinar between December and March. We got lots of questions, of course, with the new harmonized standard practice and the new regulation that came into effect on April 1st. So we have structured 4 licensee webinars that are similar in format, but are a bit tailored to each of the profession with the question that we have received. So I will introduce a little bit later who is with me to speak today. So today we are offering the webinar for opticianry and optometry, but licensee were welcome to attend any of the webinar if the time suited them better, but we have advertised that the days are for different profession. If I can move on to the next slide, I wanted to start the meeting by acknowledging that the offices of the colleges are located on the ancestral and unceded territory of the Coast Salish people, represented today by the Musqueam, Tsleil-Waututh, and Squamish Nation, and also our Victoria office, who are also on the unceded and ancestral land of the Coast Salish people of the Lekwungen Nation. So wanted to start by, again, I've mentioned that the idea of these webinar came during our HPOA webinar series. These recordings are still available on our website. If you go under the tab of legislation and bylaw, there will be a specific tab for these HPOA webinar series. The information is still highly relevant. The practice advisor are still referring people to it from time to time. Today, we're focusing on standards and regulation, but we know we've received a lot of pre-submitted questions that either relate to licensure and also a lot on the new quality assurance program. So 2 things. First, you can use these past recording to review the information. You might find the answer to your question in there. But on the quality assurance program, we will also plan separate engagement. We will have written communication that will go out to licensee probably towards end of summer, early fall. But we will also probably plan to have engagement similar to what we're doing today to be able to answer a live question and really spend a bit more time on this. So the format for today we will have the practice advisor share some information with the common themes that they've heard on standard and the regulation. And then we will take some live questions, but questions that are not answered today because they talk about quality assurance or licensure are something that we will do at another time. Can we move to the next slide, please? Just wanted to point out that last week we also had a webinar that were dedicated to all licensees. It was on cultivating safe spaces, self-care, belonging, and human capacity by Elaine Alec, who is First Nation. It was a really great webinar that spoke about you as a licensee and your practice and how to cultivate self-care, and the recording is now available on the website, so that is something that you can watch. Next slide, please. So today with me, there are 3 other speakers that you will see. We have Avin Kishore, who is our practice advisor for opticianry, and we also have Dr. Mark Bordeaux, who is our practice advisor for optometry. They will share some key information, again, as I said, from what we heard. And then we will take both the mix of the pre-submitted question and some live question. And the other person who's with me to answer a question today is Suzanne Paul, who's a regulatory practice advisor for quality practice. Susan was the lead on the harmonized practice standard and ethics. She knows ins and out your legacy standard, but also the new standard. So it's always helpful to have her there to add some information when it comes to your question. And so next slide. I've already touched on that. So while we're offering this session, we saw there was lots of question in March. We know the amount of changes that has happened since amalgamation is, to say the least, like quite big. And so we are seeing that these way of engaging with you are really a good way to answer a question that matter to you. And we're hoping to do more of these in the future. So hopefully they help to support you in understanding and applying these changes that have happened as of April 1st. Next slide. And yeah, I think I have provided an overview of all of this. We will touch on common question. We'll have time for question. And yeah, you might find in the other webinar that we've done last week, the other profession found that it was quite useful to hear from other profession asking questions on different topic and then learning from each other. So we're hoping that you can also benefit from that today, hear from your colleagues and kind of realize that, oh, that's a good question. I wanted to hear about that too. So I think I will pass it on. I can't remember who's going first. So if you can move to the next slide, I'll probably know. I'm gonna make sure here we go. Okay, so Mark, I am officially muting myself.
Okay, great. Thank you. So I'm Mark Bordeaux, practicing optometrist on Vancouver Island and part-time practice advisor for optometry to the college. So next slide. So some of the common optometry questions that I received both in lead up to this webinar as well as in practice advisor role was, how has our scope of practice changed? How long must I keep records for? And can I shred paper records after I scan them? What forms do I need to fill out with respect to records, ownership, location, name approvals, etc.? As you may remember, we had lots of forms in the Legacy College. What do I need to do to have an optometry student on rotation in my clinic? And what changes were made to marketing? Next slide. So first I'll touch on the restricted activities and scope of practice. So at this moment, there's been no changes to optometry's restricted activities or its scope of practice. So basically what we had before under the HPA has been sort of cut and pasted into the HPOA for all intents and purposes. There are some small differences that to how we are practicing, and I'll note one of them down below there. Optometrists do not have and never had the authority to order lab tests. And I know that was a confusing one for myself as well as others, because our old standards had how to handle lab tests that you had ordered in them. And that was an oversight. It's quite complicated, but the long and short is that we never had the ability to order, and we still do not. I think it's something that may come up in the future, but it touches on multiple departments within government, and so it's not strictly restricted activity. And so it's something that they'll have to see if and when they will grant us that authority. So as it pertains to scope of practice, the BCDO had a proposal in front of government to align our scope of practice with the current education and training in optometry school. Now, this was, I think, submitted last year at some point. In the meantime, government put it out for public comment, which ended on March 31st. It included the ability for optometry to use lasers for 3 specific procedures, including SLT, YAG-PI, and YAG capsulotomy, and to prescribe oral pharmaceuticals. So At this point, we don't know what's going to happen. The comment period is over, and government will then have to make a decision as to how to proceed. So the college is just waiting to hear on if and when we'll be regulating those, or some or all of those new authorities if they're given. So next slide. So one thing I'll point out, in our old standards, there was references to independent automated sight testing or auto refraction. And I just wanted to point out in the definition of prescription for a corrective eyeglass lens, it means a prescription for a corrective lens that A is prepared based on an assessment of the patient's eye health by any of the following, and that includes optometrist or medical practitioner. And that comes out of the HPOA regulated health practitioners regulation. And why that's important is because the reference to automated refraction has been removed out of the standard, but it still means that optometry must provide an eye health assessment at the time of determining a prescription and releasing that prescription to the patient. So independent sight testing or automated refraction, whatever phraseology you'd like to use, is still not allowed for optometry. Next slide. So one of the most common questions we get at the college is around records retention. And this is a big change for optometry. We used to have a different set of rules under the legacy college. 10 years was the typical window of time we needed to maintain the records for. And right now, records must be maintained for 16 years from the last visit for an adult, or for 16 years after a minor patient turns 19. So in other words, until they turn 35. So for those adult patients that were last seen before April 1st, 2016, that means they would have last been seen 10 years prior to the implementation of the HPOA. And their records may still be destroyed under that 10-year legacy policy. Similarly, minor patients that had turned 19 before April 1st of 2016 and have not been seen since may also have their records destroyed. And the reason for the change to the 16 years is it brings the retention requirement in alignment with the Limitation Act, which is another act that we pay attention to in the background. And it basically allows for the proper amount of time to pass for if anyone's interested in litigating any of these issues. So paper copies that have been scanned appropriately into a digital version may be destroyed. So you only need to have one faithful copy of a record. You do not need to keep your paper copies if you've scanned them appropriately into a digital version. Next. So what has changed with notifications to the college? So we used to have a whole bunch of prescribed forms that the college would use, and they were all written into the bylaws, and patients or practitioners would have to fill them out and send them into the college. And so there are no longer any prescribed forms that must be used for things like registering a place of practice, records ownership, records transfer, etc. I'll note that we still need approval for a business name if it uses a protected title or a name of a regulated health profession. So if optometry is the name of your business or optometrist, then you would still need the approval of the college. And there is a form for that. And you would send that along to the college, and then they would provide a approval, which you would then send to the BC Corporate Registry to get your name approved. So the notifications that the registrar must receive, they're required for location change of records, and that must be done within 30 days. There's a change in business or personal contact information or a change to one's legal name, and that's within 14 days. And then changes to personal or optometric corporation liability insurance within 7 days. And that would be like a suspension or a lack of a lack of a policy would have to be communicated to the college in those circumstances. Now, those notifications should be emailed, and they should be emailed complete with your profession in the subject line, because as you're aware, there's multiple professions and there's streams of people that handle those different professions. So if you send it with the subject line optometry to licensure at CHCPBC.org, then they'll make sure it gets to the right people. Now, it's in the future, we'll have a self-service component through the Alinity online portal. So some of these changes will be able to just be updated by yourself without actually having to send an email to the college. And we will make sure we let you know which reporting requirements have to go to the email through licensure and which may just be updated when our Alinity online portal is up and running properly. Next slide. So as it pertains to changes to notifications to patients. So at this moment, we need to provide current patients with notice to the extent possible about a change in the location of their records. So if you're going to close your practice, you're going to retire, you're selling your practice, and the records are going to change hands, at least change location, you need to inform the patient of that in advance if possible, so that they know where to find their records and may retrieve them at their will. So patients must be notified if you've discontinued their health services, which often in the emails come through as I want to fire a patient. So if you're looking to fire a patient, then you need to notify them that you're firing them. And I would use discontinuation instead of firing. And then you also need to include an explanation of why it was necessary. And if you go into the standards, it'll explain to you under what circumstances it's allowed, if you want to use that word. And so you must provide a reasonable explanation for why it was necessary. One of the common questions we get is, where's a form? Is there a standard template or a letter or a form that I could use to dismiss a patient? And the answer is no. The college does not provide any template letters or forms for discontinuing health services. So you'll have to draft that on your own. Okay. So one of the other changes were as it relates to students. So we used to have student interns and externs, and there's no longer those terminologies. There is just a student. And a student is defined as a student of a recognized education program, which if you refer to the bylaws, you'll find a list of optometry schools, and that's where the student would be considered a student of. So at this point, there's no need to notify the college about students in your practice. And that is a big change. You used to have to inform the college about that. Students can now be delegated any restricted activity if all the requirements of the bylaws are met. And in the past, it was a shorter list of restricted activities. And so that's been opened up such that students can get appropriate training on activities that are higher risk, but with supervision could be safely trained in office by the supervising optometrist. Next. So what changes were made to marketing, advertising, and promotion? So those things, marketing, advertising, promotion, they must be accurate, honest, and without claims of superiority to or disparaging of your colleagues. So words like expert, specialist, those are not allowed. That would suggest that you're better than the others. And at this point, we're not allowed to use any of that terminology. Third-party content that references your professional services or practice must be monitored by yourself. There must be a contract between you and the third party that ensures you are kept fully informed of all such communications with the public. And then these communications must be consistent with the standard. And if not, they must be corrected or deleted. So we really want to make sure we're paying attention to what's being said both by us and on our behalf and make sure we're consistent with the standard. Next. So the other development, very recent, was we're getting new license numbers. And so the current optometry license number was the registration number, and it will continue to be our PharmaNet number, which I think is better known as our prescriber number, and that will not change. So when I call into a prescription to the pharmacy, they ask me what my license number is or my prescriber number, and it will still be that same 3 or 4-digit number. We will have a new 7-digit license number that they won't care about. The Health Professions Corporation numbers are also going to change for optometry. And we used to have the legacy optometric corporations, and those numbers will change. So we don't think there'll be any MSP billing numbers that will change because those were independent of our prescriber or registration number. And so I imagine them to continue to be independent of our license number. However, I'm not assured yet that MSP won't ask us to fill out a new form with our new license number and attach that to our existing billing number. So it's a little gray at the moment, but we will find that out very quickly. So there may be some concern on third-party payers and insurers that they may want an updated license number, and so will essentially be up to you to figure out to see which third parties you have a relationship with and what their requirements are. So you may want to proactively reach out to the insurers, or perhaps that's even a question for the BCDO to answer on everyone's behalf, because maybe they can do that legwork and figure out who may have a need for the updated license number. And then with that new license number, you'll also have a new licensee portal. So we'll be able to go in to our new portal and update Alinity, and you'll find your profile there. And that's it for me. I'm going to hand it off to Aveen.
All right. Thank you, Mark. So good evening, everyone. It is a pleasure to be joining tonight. My name is Aveen Kishore, and I am the practice advisor for the profession of opticianry for the college. And I'll be taking you through some of the key updates to opticianry under the HPOA. I'll focus on what's changed, what that means in practice, and the resources available to you. Next slide, please. So to start off, these are some of the common questions we've been hearing from licensees, things like how the scope of practice has changed, what titles can be used, why did my contact lens fitting renewal look different this year, what's new with automated refraction and record keeping, and where to find guidance on dispensing and refraction. So I'll walk through each of these areas and connect them back to everyday practice. Next slide, please. So I'll start with scope of practice. Under our previous legislation, the HPA, the definition was quite broad. It simply stated that an optician may practice opticianry, and it didn't offer any additional detail. So under the HPOA, we now have a much clearer definition. So it outlines the core areas of practice for opticians, including assessing refractive error and visual acuity through automated refraction, dispensing and fitting vision appliances. Those specific vision appliances would include eyeglasses, contact lenses, and low vision aids, and advising patients on the use of those specific vision appliances. All of this is grounded in our clear purpose, which is to promote and maintain visual acuity. Next slide, please. Now, I want to take a few moments to talk about restricted activities and exemptions under the HPOA, because this is really the core of understanding who can do what in the optical environment. So under the new framework, certain tasks like dispensing corrective lenses or fitting contact lenses are classified as restricted activities. So as licensed opticians, you are authorized to perform these activities independently. So that includes not only the dispensing, but also applying your professional judgment in evaluating fit, making adjustments, and ensuring the final product meets the patient's needs. Next slide. So the regulation also has introduced specific exemptions for unregulated staff, and we often refer to these staff as frame stylists or eyewear consultants. And it's important to note that exemptions for these staff are narrow and conditional. So essentially, unregulated staff can dispense lenses only when there is a valid record in place and they are following it exactly as written. There's no room for interpretation, no calculations, and no independent decision making. Next slide, please. So extending that idea of strictly following instructions, unregulated staff can also dispense duplicated eyeglass lenses, but only when the eyeglass lenses are neutralized with the lensometer and the prescription is not altered in any way. Next slide. Thank you. So, the easiest way to think about these exemptions is that an optician can assess, decide, and adapt care when it's necessary. So things like this, practical examples of this could be adjusting a prescription for vertex distance, using Martin's rule when you're dealing with pantoscopic tilt, splitting prism when it's prescribed, or applying prism thinning to a progressive lens to support comfort and visual demand. On the other hand, unregulated staff can only follow the vision appliance record exactly as it's written. No interpretation and no adjustments to what is dispensed to the patient. So really the difference comes down to clinical judgment and professional competency, and that responsibility stays with you as the optician. Next slide, please. So shifting over to exclusive titles under the HPOA, the titles optician and dispensing optician are protected, which means that only those licensed with the college can use them. Adding the word licensed before the title is not encouraged, but it is not prohibited. So you may if you choose to. And at this point, we have not established a standard list of abbreviations. Next slide, please. I've been receiving a lot of questions about licensure for contact lens fitting under the HPOA, so let's take a moment to walk through that. Under the new framework, contact lens fitting is no longer treated as a separate designation. And the reason for this is because contact lens education is now fully integrated into all of the accredited education programs across Canada. So what that means is that that every new licensee coming into practice must successfully complete both the contact lens and eyeglass NACOR exams to become licensed in BC. So because of this shift, the contact lens fitter title and license class have been retired. If you are an existing licensee who has never fit or never was certified to fit contact lenses, nothing changes for you. You still cannot fit contact lenses. And that restriction will appear on the public registry. One important note for those individuals is that if your license lapses, you would need to complete contact lens education before having it reinstated. Next slide. Now, just to jump to automated refraction, you'll notice some terminology changes with refraction under the HPOA. What was previously called independent automated refraction is now simply automated refraction, and assessment record has changed to dispensing authority. Next slide, please. So building on refraction, there is still an additional certification required to perform sight tests or to prepare a dispensing authority, and that certification will be reflected on the public registry. What has changed with refraction is that the limits and conditions now apply specifically to the automated refraction, which forms the dispensing authority. So the details of the limits and conditions are outlined and can be found within the ethics and practice standards on our website. Next slide, please. On the topic of automated refraction, one key takeaway is that a valid dispensing authority can be used for dispensing eyeglasses and contact lenses. That was also the case before under the HPA, but under the HPOA, this has now been made clearer. The dispensing authority has to be produced within the established limits and conditions, and it must include the patient's full name, the date of the automated refraction, the optician's name, optician's business address, license number, and signature. Next slide. So another area where there's been some change is records and release. So under the HPOA, retention requirements have changed quite a bit. So instead of keeping records for 3 years after the last entry, they now need to be kept for 16 years from the last patient encounter. And for minors, the requirement is even longer. Records must be kept until 16 years after the patient has turned 19. There is also now a defined timeline for releasing records, whereas previously there was no timeline. Under the new framework, records must be provided within 30 business days when requested. Next slide, please. So another area to be aware of is where you go for practice resources and guidance. The Legacy College, COBC materials have been retired. So moving forward, the ethics and practice standards are your main source for regulatory requirements. In the past, some of the older standards, we had Standard 8, for example, which spoke to dispensing and fitting, were quite prescriptive in nature. Our new standards take a harmonized approach and they focus more on outcomes and your professional judgment rather than outlining specific step-by-step instructions. And so if you are looking for more detailed practical guidance, the National Competencies for Canadian Opticians are an excellent resource, and they're available on our website and can help support your practice. Next slide. Okay, and lastly, there is also practice support, which is available to support you and help you navigate some of these challenges or some of these changes rather. It offers confidential guidance on regulatory topics, helps connect you with the right college resources, supports informed decision making, and can link your questions back to the national competencies if needed. Overall, the shift under the HPOA is toward clearer expectations, less prescriptive direction, and a greater reliance on your professional judgment. And that sums it up for me. And with that, I'll pass it back to you, Joannie. Thank you, everyone.
Thank you. Thank you both. Okay, Anita, I think
Yes.
we will take a mix of questions. So I'll let you start, and we will ask Susan, myself, and probably also Mark and Evan to chime in as needed.
Sounds good. And it was really useful that so many folks answered the question during the registration process about what you're most interested in learning about. Hopefully you see that a lot of that has been covered, but you may have additional questions and you're welcome to submit those in the Q&A. Certainly, I think at a high level, both professions expressed an interest in getting an overview of the changes in the standards, and some said that they really wanted to hear what their peers are asking about because they thought that would be helpful to them. So that's what we focused on today. We have a question about scope of practice regulation. Where do we find scope of practice regulations? For example, glaucoma standards, limits, and conditions.
Yeah, maybe I can offer the start of an answer, and then Susan, if you want to join in. I remember this was something we had discussed with Mark too in the lead up to finalizing the last touches on the regulation. And so, Mark, you can chime in too after if you want to add anything. So our approach to harmonizing the standard, we look at well, a lot of things, but the level of where we wanted these standards to sit. So typically in a regulatory framework and at the standard level, we do want to aspire to not be over prescriptive, so that health professional like you have the flexibility in your day-to-day practice to actually adjust your practice based on what your patient needs and not what the college is telling you in terms of how you practice. So in reviewing the specific topic of glaucoma, we had discussed with Mark as to would that not be covered by our higher level standard? For example, if we look at the evidence-informed standard and evidence-informed and outcome standard, where you are asked to use the evidence available, be proficient in your assessment, determine, what the patient needs, and would that be part of an optometrist's judgment to determine who should be who qualified or doesn't qualify for that kind of procedure. And that is where we landed. And you'll find that for a lot of other topics in terms of removing some of the clinical requirement and standards so that you can apply this based on the patient needs, the specific situation, and also the evolution of the literature, research, technology, and how that influence your practice. So that's kind of a long answer to say that you won't find it in the new standard because it's It's not there anymore for this reason. It doesn't mean that suddenly, you should practice however you want. There are expectations in terms of, looking at the evidence and the patient need, but we are providing flexibility that I'm sure in your day-to-day, you'll probably know that this patient maybe is on the fence, but it's a yes because I feel confident that it's relevant, but that one, it's a no. So Susan and Mark, I don't know if you want to add anything that's more applicable or relevant to practice, but that's kind of the essence of the conversation.
Yeah, I'll just add in there something connecting also to the professional performance and responsibility standard that talks about, that we have an obligation to practice only where we're competent and to refer where a patient's healthcare needs exceed our competence or qualifications. And again, had this conversation with Mark around the legacy standards had some quite specific dates or sorry, ages. So, 40 around for glaucoma and 12 for a procedure. I can't even remember the name of it, Mark, something around the lacrimal structure. And the conversation we had was, well, is there potential that an 11-year-old, this would be appropriate? Is there potential that in some cases it would be okay to treat a 39-year-old if, you'd done a comprehensive eye assessment and so on? And would there also be cases where the 41-year-old with glaucoma should not be treated because there are red flags? And Mark said, yes, a competent optometrist will know when it's appropriate to treat that patient with glaucoma or to treat that child and when to refer onwards. And so to Joanne's point, we don't want to include that level of clinical detail where it's something that is taught in school, examined by the OEBC on your entry-level exams, and where a competent optometrist will make decisions in the best interest of the patient, knowing their own limitations around competence and when they should refer. Mark, anything? Have we reflected the conversation accurately? Want to add anything? Yeah, okay.
Good job.
Thanks, Mark.
Someone asked, you said that opticians must follow prescriptions exactly. Does this apply to expiry dates written on the RX?
I assume that the you said is Evin that said that. So, or do you?
Can we repeat the question there?
It's the person wrote, what they heard was that opticians must follow prescriptions exactly. Does this apply to expiry dates written on the RX?
So the talking point was with respect to unregulated staff. That specific point. With respect to the expiry date, the optician can, if through their professional judgment, they feel that the prescription is one that is safe to fill, they can fill one despite it being expired.
Thanks, Evin. Another question. This person is referring to the remark that to provide a patient with a prescription for a corrective eyeglass lens, it may only be prepared based on an assessment of the patient's eye health. What constitutes eye health? Is visual acuity sufficient as, quote, eye health before providing a prescription for a corrective eyewear?
That sounds like a very
I think that's
profession specific. So Mark, why don't you start? And I find that sometime when I hear the answer, I'm more able to also contextualize further what I would answer at a higher level.
Yes. So I think visual acuity all by itself is not sufficient for an eye health assessment. In this case, it would be considered what we'd probably think of as a eye exam, complete with pathology, case history, et cetera, et cetera. So that would not qualify as being sufficient.
Yeah, I was just going to add to that. The way I understood it is that Mark was pointing out that if that was the entirety of the eye health exam, that would not qualify. It doesn't mean it can't be part of. Mark, is that correct? Yeah. So again, I think that we really do want to reinforce that the way that the standards have been written in a slightly less prescriptive manner than you might be used to, it's not intended to change practice. You learned how to be a competent optometrist in your entry-level degree, and you were examined on that by the OEBC, and you've been duly licensed. So we want to recognize that those practice pieces, like you've got that you don't need to see that in a regulatory standard about how to, like, what constitutes, what the pieces are of a comprehensive eye exam. You already learned that, what that involves. But to Mark's point, it's not that it excludes you doing the visual acuity, but that wouldn't be in and of itself, that would not be a competent optometrist, that wouldn't qualify as a comprehensive eye exam, as you would have learned.
Sufficient by itself. Yeah.
Yeah.
Thank you.
Now, this was another person who previously asked the question. I think I need to clarify the situation. So if a patient returns before they are due for full eye exam, we can't just update the refraction and give an updated prescription.
I think in that circumstance, you'd have to use your clinical judgment. So if it was a healthy 25-year-old who just broke their glasses that they were seen 6 months before, maybe in that circumstance, it would be appropriate to do just a prescription check. But if it's an 85-year-old with out of control diabetes, I don't think, doing a standalone refraction after a prolonged period without an eye exam would be appropriate. But all these things are, come down to professional judgment. And so you have to think of what would be a reasonable thing for an average optometrist to do in that situation.
Yeah, I think context is everything, right? And so Mark's pointing out quite rightly there that the decision you make around one patient might be different than the next patient that walks in the door based on your decision making as an optometrist and level of risk to the patient. Yeah, and he's pointing out timelines and complexity, etc.
Yeah, and I think what I would add on that is that because I know that shift of that prescriptiveness to be more higher level, there's probably a natural fear of like not meeting standard. And then what happens if somebody complains about me, and then what will the college kind of be finding out about my practice? But I think what Mark said is how the college will look at it. Would a reasonable optometrist do that in this case? And if you didn't, and there was, consequence of harm, for example, on the patient or something, was that because it was unreasonable for you to skip that part, or was that a natural potential side effect of a procedure? So that is how and what are clinical guidelines saying in terms of what's generally expected for someone with this general profile. So it's not going to change how we're going to look at complaints. It's not meant at, kind of like, we're still looking at practice the same as we would ever before. It's still also going to be optometrists looking at a complaint. So, we would kind of ask those expectations. So I just kind of wanted to clarify, I think, those messages that nothing has changed, and kind of thinking as what would a colleague do in that situation, and would that be similar? Yeah.
Thanks, everyone, for the additional context. Now, in the submissions in advance, a few folks mentioned ethics. Now, one specific question that mentioned ethics was, where in the updated Code of Ethics does it speak to limitations on confidentiality re imminent risk to self?
So that's actually, I think, for more detail, so you can see it sort of broadly in the Code of Ethics, then you're going to want to go to the Privacy and Confidentiality Standard. I'll just pull that up to tell you which section, but there is a section. Oh, sorry. No, I'm thinking ahead now. So I think, Anita, the question is if you think there's imminent risk of harm to the patient, like they are at risk of harming themselves.
That's how I'm reading it.
Yeah. So actually, the personal, assuming that's from somebody in the private sector. So the Personal Information Protection Act would apply around privacy, and Section 18 in PIPA, the short form for Personal Information Protection Act, has a section about when you can disclose personal information without consent of the individual. And one of the things in the list, or one of the scenarios in the list, is where you have reason to believe there's significant risk of harm to the patient or others. So in that case, you could disclose, whether that's calling 911 or phoning a physician or phoning the spouse, or whatever you deem appropriate based on the information you have, where you deem there's significant risk of harm to the patient or others. The privacy legislation in BC does allow you to disclose without consent.
Thanks, Susan. This is a question that I think was answered. How long do records have to be kept for patients examined between 2016 and today?
Right. So we've got something actually on our website because it was in the newsletter, the April-May newsletter. We wrote a little piece to help sort of like do the math to help explain it. So you're welcome to look there. But the short version is, as Mark said, if that record exhausted the limitation period prior to April 1, that record can be destroyed. If it was midway through the limitation period, on April 1, the new limitation period applies. So Mark's example was if you had last seen a client 10 years prior to April 1, which was your old retention period. So if that had lapsed just before April 1, then those records could be destroyed under your legacy standards. But as of April 1, any records that you are holding that were mid-retention period now extend to the 16-year limitation period. And as Mark pointed out, that's to align both with the Limitations Act and with the legal opinion that the college sought on what the right number was. And it also puts us in alignment with what the other health regulators require, physicians, nurses, dentists, and many of the legacy or many of the other colleges that are part of the college now already had that 16-year limitation period. But that crossover piece it's about the sort of when you're holding that record. So if the limitation period of 10 years had expired before April 1, 2026, it can be destroyed. If it was midway through the limitation period, it extends to the 16 years.
Okay. We have another question, and it's about contact lens fitting. As a contact lens fitter, are we allowed to recommend products such as lubricating drops, omega-3s, etc., based on professional judgment?
So I will speak at that at a higher level because many of the profession we regulate can recommend product or like we get these type of question. And then obviously Mark and Evin, if you want to add anything that is more specific to the practice of your profession, please do so. We do have a standard of practice on marketing and advertisement and conflict of interest. That kind of comes into play when you have to recommend or sell any product. Obviously, it has to meet some of, I think Mark spoke about some of the things that are included in the marketing standard. It has to be accurate. It cannot be misleading. It has to be evidence-based. So that would be true for a product and how you speak to it. It would have to fit the need of a patient. And it wouldn't probably also, if it's not a drug, but it's a product, would have to be approved by Health Canada if it's distributed here. So those would be kind of the high level answer I can provide. In terms of that specific question, I can let either Evin or Mark chime in on that.
So yeah, I'd happy to answer that for you. If the recommendation is in the best interest of the patient and the contact lens fitter or optician now is competent in speaking to those over-the-counter drops and so forth, and again, it is pertaining to the contact lens fitting and in the best interest of the patient, then yes, we would typically be allowed to advise that. Again, but pertaining simply to contact lens fitting and not to overall eye health.
And I think, again, that's where sort of the professional responsibility around knowing who the right patient is to have that conversation with and who the right patient is to refer back. So again, depending on complexity and so on. So part of that is, with your professional judgment as an optician, knowing who the right clients are to have those conversations with and who needs further assessment or where that conversation should be had with a different health professional.
Yeah,
Okay.
and I think the good point you raise, Aveen, too, is the link to your scope of practice. So when you are going to actually recommend or even, contemplate the sale of any products, this should be in connection to your scope of practice. And then inside your own bubble of your knowledge, which is your own scope of practice, then make sure you mitigate any conflict of interest. Because if, for example, you make money out of selling that, that would have to be disclosed and considered or give an alternative to the patient. So you're not selling a specific brands. There's a bunch of information that would be included in the standard, but also the first question should be, is that relevant for this patient, appropriate and based on evidence?
Thanks, everyone. We have a question on a different topic. With a minor patient, do we need to ask for permission to discuss their exam result with the parents? So, for example, if the patient is 16.
Yeah, so I'm happy to take that one first. So nothing has changed with that question. That would be answered the same with legacy standards as it's being answered now. So in British Columbia, there's something called the Infants Act that applies to anyone who's a minor, so somebody under 19 years of age. And there's a section in that, I think it's section 17, that talks about if the minor has the ability to, I'm going to paraphrase here, but to understand the situation and the risk, including sort of risks and so on. If you determine that, and that you determine it's in the minor's best interest, if they are able to provide consent. And so in BC, there's no age attached to that. So it doesn't say at 16 they can provide consent, at 17 they can provide consent. It's more around your decision as a health professional about whether they understand the information you've provided, the risks, and whether it's in their best interest. And so that's going to be a judgment call on the part of the optometrist about that 16-year-old. In our experience, through practice advice, usually all it requires is saying to that patient, is it okay if I talk to mom about what, the results of the exam are? And 99% of the time, the child will say, or the minor will say, yes, that's fine. Sometimes they are not connected with their parents anymore, and so they may have that explanation, and that might influence how you proceed. And I would also say, when you get into tricky questions like that, that's where Mark and Naveen can be such a huge resource. And if you have a particular case that's sticky around where you're trying to determine if you should be accepting consent from a minor or the parent, because sometimes those things get complicated, it's always easiest if you ask the minor and the minor says, sure, go ahead and tell my parents. But every once in a while, there's sort of they might decline, and there might be something significant that you are concerned about. And those are the kinds of scenarios where Mark or Raveen could have a more sort of comprehensive conversation with you about the different things to consider. But technically, that 16-year-old may be deemed on your part to be able to provide their own consent, and then there's not a requirement for you to talk to mom and dad. But mostly, I think we would all agree as regulated health professionals, that's often best practice. And so very often it's simplest by asking the minor, and the minor will often give you consent to talk to mom or dad.
Thanks, Susan. I want to acknowledge that a couple of people in advance mentioned the legislation specifically. And I think the theme that they were asking about is, how did the change in legislation affect the development of the new ethics and practice standards? Now, I think somebody touched on that a little bit, but is there anything more that you would like to share in terms of the context?
Joanie, I can start, and then maybe you can add what. So certainly it was influenced by, the standards were influenced by the HPOA, because the HPOA has guiding principles that require we take into consideration anti-discrimination measures, Indigenous cultural safety and humility. And in section 70 and 72 of the HPOA, the act actually requires colleges to have standards on specific topics. So things like treating family members, a conflict of interest. So there are certain things that it actually requires, and not all legacy colleges had standards on those topics. So in some cases, it was about filling gaps between what legacy standards had and what the HPOA requires us to have standards on. And in some cases, they were sort of new requirements for everyone, where standards would speak to guiding principles that are embedded in the HPOA that we then are required to reflect in the standards. Joanie, anything else?
Yeah, I think I'll just, when we did the webinar in March, we had touched on that this was really an harmonization effort. So technically, aside from those gaps that Susan just mentioned, we did not develop new content. They look new to you because we wrote them in a way that kind of took all of the 7 legacy set into one. But the actual expectation of practice, aside from those gaps, are not new. We adjusted, again, the level of details and kind of trying to think too of right touch regulation, which is really like, let's make sure we don't create barrier in practice by adding a requirement that is not ours to have. So in terms of where our role in regulation lives, if we're talking about especially clinical guidance, or something that is starting to go too far into practice. So that is another things that have shifted. But the changes with regards to the new legislation really came from those specific duties that we had to include in the standard of practice, and obviously what came from the regulation, which set out restricted activities now that is in a centralized list, which before used to live in all of those separate regulation. But it was not meant to change like practice as it is happening today. And those new duties to like practice that we included, again, many of the profession didn't have them. Susan mentioned some example. There was like reporting, addressing, and managing sexual misconduct. Those are not new things. The conflict of interest, treating family members. So maybe how it's worded looks different to you, but that hasn't changed.
Thanks, everyone. I think it's really helpful to hear about how the governing legislation informed the standards that we've been discussing today. So we're just about coming up on time. I know there's a little bit more we want to cover, and that's it for the Q&A section.
Yeah, thank you. I did see we had quite a few questions too regarding, again, quality assurance, our future program, the continuing education pieces, licensure, because we're like lots is happening in the college. So today we were really focusing on standard and regulation, but I know that people want more information, that you have lots of questions, and also just because of the amount of changes that's happening right now in regulation, I really understand that probably you still have lots of questions left. You may have missed at the beginning of the webinar, I have mentioned that for quality assurance, we are planning to send out some written communication to all licensees towards end of summer, early fall. But we will also plan to have engagement like we did today. So you will have opportunities to ask questions if those communication are not addressing your question. And for licensure, I would encourage you to review. We have sent some communication on the changes with regards to the licensee number. There's also now an FAQ that's been published on the website. And so have a look at the source of information. If you don't find what you need, please reach out to us and we will do our best to point you in the right direction. We really appreciated the engagement. We know it's more time in your day. Everybody's busy and have a lot going on. So the fact that you take the time to come and talk with us is very much appreciated. And you can reach practice support at the email that's on this slide, and then it goes to the specific practice advisor of the profession you're asking a question. You've seen today, Mark and Evin, and they're really their desired and whole role at the college is to support you in your practice. So yeah, thank you for being here today. The recording will be made available and sent by email in the next couple of days. So have a good evening.